You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for May 23rd, 2025. This week, listener feedback on sports disqualification, big Digoxin news, Brugada Syndrome, another positive Finerenone study, and unblinded transcatheter trials. The first thing to say is that this is a holiday weekend in the U.S. It's our Memorial Day, where we honor our deceased men and women in the military. As I've gotten older, my respect for those who died serving in the military has increased. I am also off to Berlin AFib today, and as such, this might be a slightly briefer podcast than normal. First is listener feedback. Paul Dorian, a senior Canadian academic EP who has written extensively in the area of sports cardiology, wrote to me via email regarding my comments on the Mayo Clinic Return to Play genetic heart disease study that I covered last week. Dr. Dorian first agreed with my comments and the ideas of the authors who report an extremely favorable prognosis of patients who were gene positive but phenotype negative disease. Let me quote from his email because it is so educational. He writes, "I take issue with the phrase disqualification. As sports cardiologists, we never, ever disqualify any athlete from competing in a sport. Disqualification should be entirely restricted to the team, organization, or governing sport entity for a particular sport. Disqualification is a legal and organizational concept. What physicians, especially sports cardiologists, can and should do is inform the patient of the best estimate of the risk of sport, specifically tailored to the severity of the illness, the predicted risk of adverse events, including sudden death, the specific genotype and or phenotype, and the type of sport, with frequency, intensity, and duration of activity. Using the now well-accepted concept of shared decision-making, this is then up to the individual patient-athlete to decide whether they wish to participate in their desired sport or sports, and at what intensity, under what circumstances." He goes on, although physicians are sometimes asked to clear an athlete for competition or sometimes indicate that the athlete should be disqualified, this is always inappropriate and should never be done, unless the physician is representing a team or sporting organization as opposed to caring for the athlete. This, of course, does not mean that physicians should refrain from giving clear advice, including recommending against certain activities if they feel that the risk is high enough. For context, Dr. Dorian writes, the risk of dying per ascent of Mount Everest is 1%. The risk of dying from hang gliding or parachute jumping is approximately 2 per 1,000 participants. If we don't, quote, disqualify our patients or friends from attempting Everest or hang gliding or parachute jumping, why would we disqualify a patient with much less than 1% annual risk of death from participating in sport? I want to thank Dr. Dorian for writing, and I'm glad to learn from experts like yourself. Okay, the Digoxin news that I mentioned. On May 19th, the European Journal of Heart Failure published the baseline characteristics of the DIGIT-HF trial. This is a placebo-controlled RCT in patients with symptomatic HFrEF with an EF less than 30% and class 3 to 4 heart failure symptoms. It compares the safety and efficacy of Digoxin versus placebo in addition to baseline GMT. The authors published the rationale paper in 2019, and I will link to it. I did not know there was a DIGIT-HF trial going on, so I am very excited. The primary outcome of this DIGIT-HF trial will be death and heart failure hospitalizations. The motivation for the trial stemmed from the old DIG trial, one of my favorites to discuss. The DIG trial circa 1997, I'll link to that too, randomized just under 7,000 patients and found no difference in mortality, which was its primary endpoint. Now, at the time, in 97, the trial was largely considered a negative trial, as this was the era of ACE and beta blockers and MRA, and everything was reducing heart failure mortality. However, in today's terms, where almost all heart failure interventions fail to change mortality and only decrease surrogate endpoints like heart failure hospitalizations, the DIGE trial could easily be recast as a winner. Why? For 4 big reasons. One is that in the DIGE trial, the digoxin shredded heart failure hospitalizations by a statistically significant 28% over placebo. Now, this is on par with our modern-day SGLT2 inhibitors and ARNIs in HFpEF patients. 2, DIGE also reduced total hospitalizations, which in my opinion, as I've said before, is the only hospitalization surrogate that patients care about. Remember, heart failure hospitalizations are a subset of total hospitalizations. 3, subgroup analyses from the DIGE trial found a heterogeneous treatment effect, or at least a strong trend for one, where most of the DIGE benefit came from patients with more advanced heart failure and lower ejection fractions. 4, the trial procedures in the DIGE trial allowed for open-label use of DIGE in the event of worsening heart failure. And this occurred 8% more often in the placebo arm. Also notable that the DIGE trial was highly pragmatic. There was no run-in period, and no DIGE levels were mandated. Now, some might ask whether the DIGIT-HF trial enrollment of only 1,200 patients will have enough power, because, the DIGE trial had 7,000. I think that's a serious concern, but it's also possible by only recruiting the sickest of the sick HFrEF patients, they will likely have higher event rates. Though underpowered trials are a terrible thing because it's unethical to experiment on people without hope of having enough power to sort a signal from noise. Then, right after I tweeted this out, ID Dr. Todd Lee responded to me on Twitter that there's another ongoing DIGE trial for patients with heart failure. So I looked at it. In August of last year, the European Journal of Heart Failure published the rationale and design paper for the Dutch-led Decision trial, and I'll link to Decision. This is an RCT, double-blind, placebo-controlled, looking at DIGE in patients with chronic heart failure and an EF less than 50%. The primary endpoint is CV death and heart failure visits, which includes hospitalization or urgent visits. Here, the sample size is similar, only 1,000 patients, and all of these patients have been enrolled by December 23rd. Decision is powered to find a 22% reduction in the composite endpoint. I'm glad there are 2 trials, but I do worry about the power of these trials. Make no mistake, DIGE use requires care and knowledge of pharmacology. It's not willy-nilly. I know pharmacology knowledge is certainly less common in the modern clinician, but I strongly believe digoxin was unfairly maligned by biased observational comparisons where sicker patients get DIGE, and that is why there is an association with worse outcomes. I'm going to cite a meta-analysis of all DIGE studies. The first author is Ziff, Z-I-F-F. It's in the BMJ, and this is a nice meta-analysis, and it shows the association with digoxin harm falls in parallel with the robustness of the statistical methodology. And in fact, there is no association of DIGE harm when only DIGE RCTs are combined. I think digoxin can be an extremely useful adjunct to help patients with heart failure, and I look forward to the outcomes of these trials. All right, next topic is Brugada Syndrome. Now, I don't know about you, but we get a fair number of consults to evaluate patients who are unfortunate enough to get an EKG that the computer reads as possible Brugada syndrome. Now, some, perhaps most of these ECGs can be simply put off as misdiagnosis because incomplete right bundle branch block is a common normal variant. But for patients who likely have true Brugada syndrome and are asymptomatic, and that's the majority, it's a struggle because there is a tiny but asymmetrically terrible risk of ventricular arrhythmias and possible sudden death. Now, everyone agrees that ICDs should be used for secondary prevention of a second cardiac arrest, but for primary prevention, when nothing has happened in a patient with Brugada syndrome, the ICD harms likely outweigh the benefits. Now, if only there were prediction models, like the totally accurate, helpful CHA2DS2-VASc score. Well, A paper from the group of Rui Providencia in London has subjected the many risk prediction models of Brugada syndrome to systematic review and risk of bias assessment. The first author of this paper is Daniel Gomes, and it's in Europace. The first thing to say about this paper is that there are at least 11 multi-parameter risk scores for predicting major arrhythmia events in patients with Brugada syndrome. The first thing is, I didn't know there were that many risk scores. The second finding of the systematic review was that 100% of these models were assessed as an overall high risk of bias. Third, the pooled C statistic for each model had a ton of heterogeneity and lower discriminative power than originally reported. The author's second paragraph of the discussion outlined the challenge of prediction in Brugada syndrome. At present, almost two-thirds of patients with Brugada syndrome are asymptomatic at the time of the diagnosis, and up to 0.2 to 0.6% per year will eventually develop ventricular arrhythmias or sudden cardiac death as the initial presentation. They then write that clinicians, of course, need to balance that tiny risk against a cumulative ICD complication rate of 4 to 6% per year, many-fold higher. Now, think about the problem of Brugada syndrome or any disease where a risk of a terrible event is 0.2 to 0.6%. How do you predict an event with that low of an incidence? I mean, we can try, but I think it's best to be super humble, calm, and reassuring in the exam room when talking to these Brugada syndrome patients. And it turns out in Brugada syndrome that there is a good list of general preventive measures to go over. These include things like aggressive treatment of fever, avoiding dehydration, or drugs that induce ST segment elevation in the right precordial lead, such as class 1 antiarrhythmics, some anesthetics, and psychotropic drugs. We can also have these patients avoid recreational substances such as cocaine, cannabis, and excessive alcohol intake. All of these things can exacerbate the type 1 pattern and trigger VF. Now, to be fair, I am no expert in the assessment of models. That's above my pay grade as a clinician. But I cover this fairly technical paper for the same reason I covered the genetic heart disease paper last week. Our modern technology and testing have increased the number of asymptomatic people that we find that are harboring conditions like Brugada syndrome, which is a problem with prediction because they have an incredibly low risk of a terrible event. And I think the digital health revolution where we have testing and monitoring and ECGs everywhere is certainly going to bring more of these problems, not less. Okay, next topic is another Finerenone study has been published. Now, I have seen aggressive marketing, right? Watchman, CardioMEMS, Entresto, but Finerenone may be the champion of marketing. At the ESC heart failure meeting and simultaneously publishing in the Journal of Cardiac Failure, the Fine Arts HF authors report the results of a substudy of a small subset, approximately 1,000 of the total 6,000 patients in the trial. Now, I don't have to tell you the top-line results of this substudy because you already know them. The sky is blue and every Finerenone study is positive. First, let's briefly review the Fine Arts HF trial. New England Journal of Medicine, 2024, Finerenone versus placebo in 6,000 patients with HFpEF. The mean age, 72 years, almost half female patients, and the mean ejection fraction was 52%. The primary outcome was CV death or worsening heart failure event, which included a heart failure hospitalization or urgent visit for heart failure. The Finerenone arm in the main trial had a 16% lower rate of the composite endpoint, which was statistically significant. The absolute risk reduction was 2.8%, but there was no difference in CV death. Lower rates of heart failure events drove the positive results of the Fine Arts HF trial. Total death was also not statistically different. The core problem of course was that this Finerenone trial, like all Finerenone regulatory trials, were compared against placebo rather than the $4 per month spironolactone tablet. Now, purists will say, John, there is no proof that spironolactone reduces outcomes in HFpEF. That's why we studied it against placebo. And purists would cite the negative TopCat trial. And this would be technically correct. But when TopCat was analyzed, without the outlier countries, Russia and Georgia, it was totally clear that spironolactone reduced outcomes in HFpEF. Of course it does. Any doctor who treats patients with HFpEF knows that spironolactone is like a secret weapon. Now, if we had robust regulatory authorities at FDA, they would have forced Bayer to design their regulatory trials against spironolactone. If I were at FDA, it is what I would have required. Or at least do a 3-arm trial with Finerenone, spironolactone, and placebo. So anyways, the latest Substudy took 1,000 patients of the total 6,000 who had been randomized during a heart failure hospitalization or shortly after. Now, in fine arts, recall that the proportion of patients without a worsening ambulatory or a hospitalized heart failure event within the 3 months of randomization was prospectively capped at approximately 50% of total enrollment. Now, the purported idea was to capture a unique cohort at risk for readmissions and to examine the effectiveness of early initiation of Finerenone on short-term readmission endpoints. And, of course, you guessed it, among these patients, 30-day readmissions for heart failure were 1.8% versus 3.6% in those randomized to placebo. That hazard ratio was 0.55. Similar results were observed when examining 60 and 90-day heart failure admissions. And of course, you can see the marketing potential here, right? Because heart failure readmissions is an area of focus among the quality people, of course, because it can bear on reimbursement. Now, the proponents of Finerenone can say, look, we have a drug that reduces heart failure readmissions. And I would say, come on, you all. First, this is a small subgroup of a trial with a mere 16% reduction in a composite primary endpoint of heart failure events, with no difference in heart outcomes like CV death or all-cause death. And a quite weak comparator arm, as I've already said, placebo is not the proper comparator arm. What's more, what do you think happens if you randomize a group of patients sick enough to have a heart failure hospitalization to getting an extra diuretic in addition to their loop diuretic versus no extra diuretic? Of course you get fewer readmissions. In sum, I have little doubt that MRA drugs are effective in all patients with heart failure regardless of ejection fraction. The question is whether the non-steroidal and surely more costly Finerenone is better than spironolactone or eplerenone. The final topic today is another opinion on unblinded transcatheter intervention trials. I have opined often on this podcast about the use of subjective endpoints in transcatheter trials which are open label. The problem is, of course, is that one group gets an intervention with its huge caring signal and the other group gets no procedures, tablets only, probably bland white tablets. Now close your eyes and picture the scene in a valve clipping procedure from the patient's perspective. The patient meets at least 2, perhaps 3 specialist doctors in the prep area. Then they go in the room, the procedure room, and they see these massive booms, these huge screens, multiple people. And even if you give them GA, the impression is when they wake up, holy mackerel, I remember that room. This procedure has got to help me. The control arm gets nothing. But also, they know they could have been randomized to the procedure. It's a huge problem. Well, I'm delighted to tell you that Sanjay Kaul, surely one of the best evidence adjudicators in all of medicine, wrote a short editorial in the journal Eurointervention, where he persuasively argues that open-label trials are rarely adequate to support labeling claims based on patient-reported outcomes. Now, I want to thank Sanjay for his incredible generosity for me. He has taught me so much over the years. He is really excellent. And I highlight his editorial because I want you to know that it's not just a podcaster who's telling you that these transcatheter trials are problematic. Now, in the editorial, Kaul cited a great example, one that I forgot about, actually. Perhaps you know it. He contrasted 2 trials of hemodynamic monitoring. One was the GUIDE-HF trial of invasive hemodynamic monitoring in heart failure patients, and it used a blinded assessment of quality of life. Here, in GUIDE-HF, I remember every patient got a CardioMEMS device and its use was then blinded. GUIDE-HF found no difference in quality of life. But the MONITOR-HF trial, which was similar, was an open-label trial of hemodynamic monitoring. And guess what happened? it showed an improvement of the KCCQ in the patients who had the device. Now, Call's article is a tour de force argument in favor of using proper sham controls for devices. It's an important concept, I think, especially now in topical, because the cardiology space is iterating so fast with these new devices. I was talking yesterday with a nurse who's my age, and we were just reminiscing about the old and the new and how much more we have now. Now, one depressing feature of this story is that it would be super easy to do these blinded trials. I mean, think about the tricuspid valve interventions. You simply sedate the patient and put a catheter in the femoral vein, and you have a sham-controlled procedure. Now, whenever you think a placebo procedure is unethical or risky, we can't do that, Mandrola, I ask you to think about two things. One thing to think about is the counterfactual, where we would still maybe doing LEMA, ligation, or TMR, transmyocardial revascularization, if not for sham-controlled trials showing that they weren't effective. And the second thing to think about is to go look at the angiograms in the Lancet supplement of the Orbita trial. Look at those angiograms. Half of those scary lesions were initially treated with nothing. That should reassure you that sham controls are possible. Finally, and perhaps the most depressing part of the unblinded transcatheter trials, is that I know, and you know, that the investigators know that blinding is necessary. And medical investigators are supposed to be scientists and clinicians. Now, scientists should not need regulators to push them to do proper trials. If they're scientists, they should just do proper trials. And as clinicians, they use the placebo effect nearly every day in the office, so they know that proper sham controls are needed from the clinical perspective. Yet they did not do it. I'm just sad about this whole thing. And that's it for this week in cardiology. As always, I'm grateful that you listened, and thank you. And if you like this podcast, please take the time, give us a rating, write us a review, do what Dr. Dorian did. If you don't agree with something I said or have something to say, write a comment on the website, send me an email, and we'll learn from it. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.